It's a great pleasure to be among you all in this prestigious gathering. The title of my talk is The Autofluorescence Signature of Parathyroid Adenomas on Contrast-Free NIRAF Imaging, Assessing Correlation with Cell Type, Size, and Location. My co-authors and I have nothing to disclose. According to the American College of Surgeons Committee on Emerging Surgical Technology and Education, the worth of any newly introduced surgical technology is measured on the basis of the value and safety it confers for patients. Accordingly, when considering the true utility of a novel and potentially useful technological surgical adjunct, the ability of this technology to achieve its primary endpoint needs to be verified. In thyroid surgery, there's a general overall consensus in the literature that NIRAF imaging achieves its primary endpoint, considerably minimizing the risks of both transient and permanent hypoparathyroidism. However, the primary endpoint in surgery for hyperparathyroidism is to considerably minimize failure rates. Despite surgical cure rate in surgery for hyperparathyroidism being exceedingly high, ranging between 95 and 98%, failure can still occur. And the obstacles faced by contrast-free NIRAF imaging is related to the heterogeneous pattern of pathologic parathyroid glands. And the other thing is the limited depth of tissue penetrance of near-infrared light, which prevents adequate signaling from ectopic parathyroid glands or those concealed by overlying tissue. Therefore, our objective was to assess whether parathyroid adenomas demonstrated a characteristic or uniform pattern of autofluorescence, and whether certain patterns of autofluorescence correlated with some intrinsic characteristic of parathyroid adenoma itself, such as its size, its site, or predominant cell type. And this, in turn, could help verify whether NIRAF imaging could serve potentially as an intraoperative diagnostic tool for the identification of parathyroid adenomas in real time. So this is a retrospective study of consecutive patients who underwent surgery for hyperparathyroidism in a 7-month period. And the 3 predefined classes of autofluorescence from the literature we used were high-intensity autofluorescence, low-intensity autofluorescence, and cap autofluorescence, where we know that the adenoma itself demonstrates low-intensity autofluorescence, whereas the peripherally compressed normal rim of parathyroid tissue demonstrates high-intensity autofluorescence appearing as a bright cap. This is another example from one of our ectopic or mediastinal cases where we can see the cap phenomena very well. I won't go into detail of our results, but I'll head straight to what is pertinent to our primary endpoint. So we had 24 patients. They all had single adenomas, except for a single case of post-renal transplant tertiary hyperparathyroidism with histologically proven triple adenomas. Therefore, the total number of parathyroid adenomas under study was 26. As you can see from the table here, that 38.5% of the cases demonstrated high-intensity autofluorescence. A similar proportion demonstrated low-intensity autofluorescence, and around 20% demonstrated cap autofluorescence. And here comes our surprise. We discovered a new pattern of autofluorescence that has not yet been reported in literature that we call the double cap pattern of autofluorescence, or I like to call Bakkar's patterns of autofluorescence. So if you look at the gross image, we can see 2 rims of high-intensity autofluorescence. Well, my first assumption was that we have 2 caps, or 2 peripherally displaced normal parathyroid tissue, and this explains the image. But then I had a closer look. You can see the one on your left-hand side here. It is within the confines of the parathyroid adenoma. So I correlated the macroscopic image with its microscopic counterpart. And interestingly, we did, one of the caps represented peripherally displaced normal rim of parathyroid tissue. However, the other represented a fatty component within the parathyroid adenoma itself. And this is another close-up of the histologies, right? You can see the chief cell adenoma here, number 1, and this is its fatty component. So by going back to the table of our results, we can see that none of the patterns of autofluorescence prevailed considerably, and there was no clinically significant correlation between any pattern of autofluorescence and parathyroid adenoma size, site, or predominant cell type. However, it is worth to mention at this point that all of our mediastinal parathyroid adenomas demonstrated uniformly cap autofluorescence. And when compared to inferior parathyroid adenomas and superior parathyroid adenomas, the results were either clinically significant or near clinical significance. However, this information is considered meaningless. Why is that? For the first reason is that we cannot use near-RF imaging as a diagnostic tool for ectopic parathyroid adenomas. These, and that is related to the limited depth of tissue penetrance of near-infrared light, so it cannot elicit adequate signaling from ectopic parathyroid glands, which are typically sought for based on preoperative localization studies. And the second reason is that the number is too low. We had only 2 ectopic parathyroid adenomas in our series, so we need a larger sample to make valid comparisons. So what about considerable, any impact on operative time or cost? Well, the impact on operative time was unremarkable, only a few minutes added. However, a considerable additional cost applied. However, unfortunately, cost was not marginalized by any benefits that we could attribute to the use of this technology in surgery for hyperparathyroidism. We could better understand this if we compare using the technology for thyroid surgery, where it achieves its primary endpoint, minimizing both post-operative transient and permanent hypoparathyroidism, and therefore cost marginalization becomes evident through considerable cost saving in terms of treatments required for post-operative hypoparathyroidism, their length, and physician visits. So I think that these characteristic patterns of parathyroid adenoma autofluorescence are very important and very helpful, and they can be considered pathognomonic, and they can be used as optical biopsies or for spot diagnosis in surgeries for hyperparathyroidism. However, the main drawback in our study that the incidence of such characteristic autofluorescence patterns was low. So we can see 19 and 4% respectively. So what are perspectives for the future? I think that surgeons have to invest more time looking at pathologic parathyroid adenomas in situ and at the surgically resected specimen, so that maybe we could discover more pathognomonic or characteristic autofluorescence patterns. As for the manufacturer, I think that if they put more focus on not only detecting normal parathyroid tissue, but also trying to detect pathologic parathyroid tissue, near-RF imaging could be the new frontiers in hyperparathyroidism surgery. To conclude, parathyroid adenomas seem to lack a characteristic autofluorescence pattern. This, along with the considerable cost added with no cost marginalization, this implies the limited diagnostic role of NIRAF at this stage, apart from confirming the surgeon's perception of normal parathyroid tissue. Thank you very much.